If you sit on the toilet and feel that the stool is already there, but no matter how long you wait or how hard you try, it simply will not come out. You need to understand what is actually happening. Many people call this constipation, but constipation is a broad term, and that feeling of stool being stuck near the rectum can happen for several different reasons. Sometimes stool has moved too slowly through the colon and become unusually dry and hard. Sometimes a hard mass has collected low in the rectum, and in some people, including older adults, the muscles that should relax during a bowel movement are not coordinating properly. The important point is this: pushing harder is not always the answer. In fact, one of the biggest mistakes is repeatedly straining or suddenly adding large amounts of bulking fiber when hard stool is already sitting near the exit. Stay with me, because in this video, I will explain 6 practical strategies, including what you can do when stool already feels stuck, how to reduce the chance of it happening again, and the warning signs that mean you should stop treating the problem at home. Here on Senior Health, the goal is to help you understand what is happening inside your body in clear, practical language, especially after 60. So first, let us understand the simple anatomy behind this problem. Your large intestine does more than move waste forward. It also absorbs water. As stool travels slowly through the colon, more water is removed from it. If transit becomes too slow, the stool can become increasingly dry, firm, and difficult to pass before it even reaches the rectum. By the time that hard stool arrives low in the bowel, it may already be difficult to evacuate. And once it becomes trapped near the exit, repeated straining does not necessarily solve the problem. It can increase pressure, discomfort, and frustration without correcting the reason the stool is not passing. There is also a mechanical factor that many people have never been taught. The final part of your bowel is not simply a straight pipe. A muscle called the puborectalis muscle helps maintain an angle between the rectum and the anal canal. When you are standing, walking, coughing, or lifting, this muscle helps maintain bowel control. But during a bowel movement, the pelvic floor muscles and the puborectalis need to relax and coordinate properly so stool can pass more easily. If that relaxation does not happen well, you can feel as though the stool reaches the exit and then stops. This is why pushing harder can sometimes make the experience worse rather than better. After 60, several other factors can add to the problem. Physical activity may decrease, fluid intake may become too low. Certain pain medicines, iron supplements, and other commonly prescribed medicines can contribute to constipation. Bowel movement can also become slower, particularly when reduced activity, dehydration, illness, or medicines are added together. And there is one pattern that often confuses people. Someone can have hard stool retained in the rectum and still notice small amounts of loose stool or leakage around it. So what appears to be diarrhea or poor bowel control can sometimes exist alongside retained stool. That is why the correct question is not simply, how can I push this stool out? The better question is, why is it stuck and what is the safest way to help the bowel empty? That is where we go next, beginning with a simple change in toilet position that can make evacuation easier without forcing your body. Let us begin with the first strategy, because it follows directly from what we just discussed about the puborectalis muscle and the angle of the rectum. Strategy number 1, improve your toilet position. When you sit upright on a standard toilet with your feet flat on the floor, your knees are often at roughly the same level as your hips. For some people, this position makes evacuation more difficult. A simple way to change that angle is to place your feet on a small, stable stool so that your knees rise slightly above your hips. Lean forward gently, keep your shoulders relaxed, and allow your abdomen to soften. This position does not magically remove an impacted stool, but it can make evacuation easier for some people and reduce the need for excessive straining. The important word here is relax. If you're holding your breath and pushing as hard as possible, you may be working against muscles that need to relax during a bowel movement, so do not turn the toilet into a strength exercise. And if this is the number one problem you recognize in yourself, sitting, straining, and still feeling that something is not coming out, comment the number 1 below. Now let us move to the second strategy. Strategy number 2. Use hydration correctly. You have probably heard the advice, drink more water. That is useful, but you need to understand what water can and cannot do. If you regularly drink too little, stool can become drier, firmer, and more difficult to pass. Good hydration helps reduce the chance that the next stool becomes excessively hard. But drinking extra water today will not instantly soften a hard mass already sitting in the rectum. That distinction matters. A useful morning routine is to drink a glass of water and have breakfast at a regular time. Eating activates what doctors call the gastrocolic reflex. In simple language, when food enters your stomach, the digestive system receives a signal that more material is coming in and the colon increases its movement. The morning meal is a useful time to take advantage of this reflex. Sitting on the toilet calmly after breakfast can therefore be more effective than repeatedly forcing yourself to go at random times during the day. Now we come to strategy number 3. Choose fiber according to the situation. Fiber is important for long-term bowel health, but more fiber is not always better at the exact moment stool feels trapped. Soluble fiber found in oats, psyllium, fruit, and legumes holds water and can help produce softer, better-formed stool. Prunes can also be useful because they contain fiber and sorbitol, a naturally occurring sugar alcohol that helps draw water into the bowel. Kiwi fruit is another practical option, and clinical studies in people with constipation have shown that regular kiwi consumption can improve stool frequency and consistency. These foods can help reduce repeated episodes of hard stool. But remember the main rule. If you already have severe rectal pressure, significant pain, or a hard stool that truly feels impacted, do not suddenly load your diet with large amounts of bran or other bulking fiber and expect it to push the blockage out. Adding more bulk behind a hard mass can increase discomfort. The right fiber is useful when you use it at the right time and in the right amount. So far, we have improved the exit position, supported hydration, and improved stool formation. But there is another part of this problem that many people overlook completely. Your bowel responds to movement, and that is where strategy number 4 becomes especially important. Now we come to strategy number 4. Use movement to support a regular bowel pattern. Your intestine is not a passive tube. Its walls contain an extensive network of nerves called the enteric nervous system. These nerves help coordinate the muscular contractions that move stool through the bowel. Regular movement supports bowel health and reduces long periods of inactivity, which are common in many older adults. You do not need an intense workout. A practical option is to take a regular walk after breakfast, especially if you spend much of the day sitting. This fits naturally with the gastrocolic reflex we discussed earlier. After a meal, the colon becomes more active and gentle movement can support a more regular routine. Let me give you a simple example. A 9-year-old retired school teacher, whom we will call Mr. Arvind, had been passing stool only every 3 or 4 days. He spent most mornings sitting after breakfast. He was drinking water and taking fiber, but his daily routine involved very little movement. He began adding a gentle walk after breakfast and kept the timing consistent. Over the following weeks, his bowel pattern became more predictable and he was straining less. The lesson is not that walking is a cure. The lesson is that when inactivity is part of the problem, regular movement can support the rest of your bowel routine. If your balance is poor, your joints are painful, or you have not exercised for a long time, choose movement that feels safe. A slower walk, gentle indoor movement, or light household activity is still useful. Now we come to strategy number 5. Stop repeatedly ignoring the urge to pass stool. Inside the rectum are stretch-sensitive nerves. When stool enters and expands the rectal wall, these nerves send a signal to your brain. That signal is the urge to go. Your body is telling you that this is a good time to empty. But many people repeatedly suppress that signal. They are busy. They are traveling. They do not like using a public toilet. Or They simply decide to wait until later. The problem is that the urge can fade. When you repeatedly delay a bowel movement, stool can remain in the bowel longer and become harder before evacuation. That makes the next bowel movement more difficult and can gradually disturb a regular bowel habit. So when a genuine urge appears, do not make a habit of ignoring it. If your urge has become weak or unpredictable, begin building a regular routine. Choose a consistent time each morning, ideally after breakfast. Sit on the toilet for about 5 to 10 minutes with your feet supported in the position we discussed earlier. Do not sit there for 20 or 30 minutes. Do not hold your breath. And most importantly, do not force. Give the bowel an opportunity to empty. If nothing happens, get up and try again later when the urge returns. This routine can help establish a more predictable bowel habit. And notice the pattern. Position can reduce unnecessary resistance. Hydration supports softer stool. The right fiber improves stool formation. Movement supports a healthier daily routine. Responding to the urge protects the normal timing of evacuation. If this information is helping you understand your bowel better, subscribe to Senior Health. The goal is to give you practical health information that is clear and useful after 60. But what if the stool is already hard, already sitting low in the rectum, and these daily strategies are not enough? That is where strategy number 6 becomes important, because now we need to discuss short-term relief, what can actually help, and what you should not do out of desperation. Now we come to strategy number 6. Know what to do when the stool already feels stuck. This is where you need to separate ordinary constipation from possible fecal impaction. If your bowel movements are simply infrequent or the stool is harder than usual, an osmotic laxative such as polyethylene glycol or PEG is one of the best supported over-the-counter options for chronic constipation. PEG works by holding more water in the bowel, helping stool become softer and easier to pass. It can be useful for constipation, but it is not an instant solution for every hard stool already trapped low in the rectum. If you have a hard mass sitting near the exit, strong rectal pressure, or repeated attempts to pass stool without success, an oral laxative may not be enough. A treatment that works directly in the rectum may sometimes be more appropriate. Glycerin suppositories act locally and can help stimulate rectal emptying. But when there is true fecal impaction, some people need an enema or manual removal of hardened stool by a healthcare professional. This is especially important in frail older adults or when the blockage is severe. So remember this rule: do not keep adding more fiber, taking several different laxatives, or pushing harder simply because you are desperate for relief. And do not assume that stimulant laxatives are automatically harmful. Medicines such as bisacordyl and senna have a legitimate role in constipation treatment. Bisacordyl can be useful for short-term or rescue treatment, while senna can also be appropriate for some people. The important point is to use the right medicine in the right dose for the right situation, not to keep treating persistent constipation without finding out why it keeps returning. Older adults should generally avoid sodium phosphate enemas unless a healthcare professional specifically advises them, especially if kidney disease, heart problems, dehydration, or medicines that affect kidney function are part of the picture. These products can disturb fluid and electrolyte balance and can be risky in vulnerable people. If you are finding these practical distinctions useful, comment relief below. It tells me you want more clear explanations about bowel health after 60. Now I need you to understand when this stops being a home care problem. Seek urgent medical attention if constipation comes with severe or increasing abdominal pain, repeated vomiting, marked abdominal swelling, or an inability to pass gas as well as stool. That combination can indicate a bowel obstruction. Do not keep taking home remedies while waiting for it to settle. Blood also deserves attention. A small amount of bright red blood can occur with hemorrhoids or an anal fissure after passing a hard stool. But new, repeated, or unexplained bleeding needs proper medical assessment. Black, Tar-like stool is different. It can indicate bleeding higher in the digestive tract and requires prompt medical attention. You should also arrange a medical evaluation if you develop a new and persistent change in bowel habit, especially after 60, or constipation accompanied by unexplained weight loss, increasing fatigue, persistent abdominal discomfort, or a repeated feeling that the bowel never empties properly. These symptoms do not automatically mean cancer, but they should not be dismissed as normal aging either. And if tissue appears to protrude from the anus during or after straining, especially if it does not go back in, you need assessment for possible rectal prolapse. The message is simple. Use home strategies for uncomplicated constipation. But when stool is truly impacted, symptoms are severe, or warning signs appear, the answer is not to push harder. The right decision is to have the blockage properly assessed and treated. Once you understand that difference, all 6 strategies begin to work together as one practical system, and that is what I want to bring together next. Now let us bring everything together into a practical plan. The 6 strategies we discussed work best as one system. First, improve your toilet position so you are not creating unnecessary resistance at the exit. Second, maintain good hydration through the day so the next stool does not become excessively dry. Third, use fiber wisely. Soluble fiber, prunes and kiwi can support softer stools, but do not suddenly add large amounts of bulking fiber when hard stool already feels trapped low in the rectum. Fourth, keep your body moving. A regular walk or other safe activity helps reduce long periods of sitting. Fifth, respond when your body gives you the urge to pass stool. Do not repeatedly postpone it until the signal fades. And sixth, know when you need short-term treatment rather than another home remedy. Let me give you a simple example. A 73-year-old woman, whom we will call Mrs. Meera Sharma, had been struggling with difficult bowel movements for nearly 18 months. She used fiber and occasional laxatives, but she still felt that stool would come down into the rectum and then stop. Over time, she began to believe that this was simply part of getting older. When her routine was reviewed, several factors emerged. Her overall fluid intake was low. She spent long periods sitting. She often ignored the urge because she preferred to wait until she was at home. And whenever stool became difficult to pass, she ate more bran and strained harder. The approach needed to change. She improved her hydration, established a regular toilet routine after breakfast, used a better toilet position, added gentle daily walking, and stopped forcing when nothing was happening. Most importantly, she understood that when hard stool already feels trapped low in the rectum, the answer is not automatically more fiber. Over the following weeks, her bowel pattern became more predictable and severe straining became less frequent. The lesson is that you need to identify which part of the system is failing. Is the stool too hard? Are you sitting for most of the day? Are you repeatedly ignoring the urge? Are you straining against a pelvic floor that is not relaxing properly? Or is there retained stool in the rectum that needs proper treatment? Some people continue to struggle despite adequate fluids, fiber, and correctly used laxatives because the main problem is not stool formation. It is the muscles involved in evacuation. The pelvic floor muscles and the puborectalis muscle must relax and coordinate at the right time. If they tighten instead of relaxing, you can feel as though stool is stuck at the exit even when the stool itself is not extremely hard. This is why persistent difficulty emptying the rectum deserves proper evaluation rather than endless self-treatment. And in another video, we will explain how to recognize when the pelvic floor, not the stool itself, is the real problem. So remember the main message from today. Do not simply push harder. Improve the position. Support hydration. Choose fiber intelligently. Keep moving. Respond to the urge, and use the right short-term treatment when it is genuinely needed. You do not need an extreme routine, you need the right method for the right problem. If your symptoms are new or worsening, or you develop bleeding, unexplained weight loss, severe abdominal pain, vomiting, or an inability to pass gas, get medically assessed rather than trying to manage everything at home. If this video has helped you understand a problem that many people feel too embarrassed to discuss, give this video a like and share it with someone who may quietly be struggling with the same issue. That simple conversation can prevent unnecessary discomfort